A very good afternoon to all. I'm Dr. Uttara Mohan from the IIP Digital Media team. We are live today for this session on IIP India YouTube channel. The topic for this webinar is case discussion on management of traumatic spinal cord injury level 1. It is being organized by IIP Neurology Subgroup. The panelists for today are Dr. Piyush Mittal, Dr. Chitra Kataria, Dr. Jayashree Sutaria, and Dr. Narina Gupta. The conveners are Dr. Jaspreet Khan and Dr. Shraddha Devan. Before we start, I would like to let you know about the IIP Digital Media team. It's a group of physiotherapists under the association who handle the Zoom platform, webinar live streaming, and the social media profiles of IIP on Facebook, Instagram, Twitter, LinkedIn, and YouTube. You can follow IIP on these platforms to get regular notification of our upcoming events. You can also subscribe to YouTube channel to get regular notification during our live webinars. We'll be sharing the social media links in the chat shortly. Now I request Dr. Jaspreet to please take over.
Thank you, Dr. Uttara. Good afternoon, everyone. So today I, Dr. Jaspreet, on behalf of IAP Neurology Subgroup, welcome you all today to the case discussion series 2. Today's topic is management of traumatic spinal cord injuries, especially level 1. So today we'll discuss about the complete injuries of this. Before that, I proceed. We will just let you know that we have with the support of IAP, Dr. Ruchi, Dr. Sanjeev Jha sir, Dr. Suresh Babu, and Dr. K. Annamalai sir, we have started the neurology subgroup, which has been composed to spread awareness regarding the neurological rehabilitation among the physiotherapy fraternity. And we are all aware that soon we are going to have Asia West Pacific Conference AWP under the banner of World Physiotherapy in New Delhi in September 2026 on 26 and 27 September at Yashobhumi level. So neurology subgroup is a part of AWP and soon it will be a future component of WP. And we're very, very thankful for IAP for creating this subgroup and giving us all the opportunity to spread our wings and bring physiotherapy to a level of much higher, creating awareness among the all. So if you see, these are all the members of neurological subgroup who have been working tirelessly to create awareness. Through this, we have various events being organized throughout the year, in which we have case discussions, seminars, panel discussions, quiz, some special guest interviews, etc. are being happening every time during the month. So we request you to please follow and join us for the eventful things which are happening. So not taking much time, I would like to also thank Dr. Uttara for the technical support she has been given us to bring this live webinar to you. Moving further, I will introduce you to our today's panelist. So we have first among us Dr. Piyush S. Mittal. He is the Director, Government Spine Institute, College of Physiotherapy, Ahmedabad. Sir is an accomplished professional with various publications and has been invited as a speaker in numerous conferences and CMEs. Sir has an extensive experience in spinal cord injury work. We welcome you, sir, today to the event. Then we have among us Dr. Chitra. Thank you, sir. Dr. Chitra Kataria. She's a professor and principal of ISI's Institute of Rehabilitation Sciences and Injuries Central Multi-Speciality Hospital, New Delhi. Ma'am has more than 35 years of experience. She has received many awards and accolades for her extensive work in spinal cord injury. We welcome you, ma'am, today to the webinar. Thank you for joining us, ma'am. So next we have Dr. Jayashree, ma'am. She's a senior lecturer in charge principal, Government Physiotherapy College, Government Spine Institute, Ahmedabad. Ma'am has over 29 years of experience and having a rich clinical and academic experience. So we thank you, ma'am, for joining us, and you will be sharing your experiences with us.
Thank you.
Next, we have Dr. Nalina Gupta. She's professor and principal, College of Physiotherapy and Rehabilitation, University, Ambala. She has more than 19 years of experience and she has been involved in research, academics, clinics, and she has done an extensive work in spinal cord, have been given various rewards, and this more than 50 publications, 9 intellectual properties. So we welcome you, Dr. Nalina, to the webinar.
Thank you.
So not taking much time, and I'll begin with this. This is the case. So patient's medical history, patient name Mr. Rohan Patel, age 28 years, occupation construction site supervisor. The mechanism of injury was the patient sustained a fall from height approximately 15 feet at a construction site, and then he landed on his feet followed by buttocks. Immediately he experienced severe lower back pain and inability to move his legs, and then he was brought to the emergency department within 2 hours of the injury. So looking into the initial emergency assessment which was done at the emergency department, a primary survey, airway was patent, breathing was stable. If you see, circulation was, the blood pressure which was checked was 100/60, and his heart rate was 110. His disability level on GCS scale, they found it was 15/15, and exposure, there was no external bleeding found in the patient. But the key complaints or the chief complaints which the patient was giving was severe pain in lower back, complete inability to move both the lower limbs, and numbness below the waist. On neurological examinations, on motor examinations, we found that there was no power among any of the muscle groups in the lower quadrant. So upper limb power was 5 out of 5. The sensory examination, we could see that loss of sensations below L1 dermatomes. There was absent pain and temperature sensations below the umbilicus. Light touch was impaired below L1. Looking for the reflexes, knee jerk, ankle jerk, anal reflexes, all were absent. And Babinski's was negative initially. Then autonomic findings, urinary retention was there, loss of voluntary bladder control, and bowel sensation was absent. On the radiological findings, on X-ray, immediately we saw that there's a compression fracture at L1 vertebra. But further investigations on MRI showed that there's a burst fracture of L1 vertebral body and a retropulsed fragment compression of the spinal cord. Some spinal compression of 50% was seen with cord edema at T12 and L1 level. So on Asia impairment, we found that it is a complete spinal cord injury and there is no motor or sensory function preserved below the injury level. So now I'll proceed towards the panelist. So my first questions are to Dr. Piyush sir. Sir, looking for our students and if the clinicians all have joined, could you please explain what exactly happens to the spinal cord in an L1 burst fracture?
Yeah, thank you for inviting me for this session. I'm always associated in this college, in this institute with the physiotherapists around me. So it's a good opportunity for me. But what I want to tell is that what exactly, if you are asking for the spinal cord injury, what happens is we know everyone knows that where the spinal cord ends. So it is lower end of L1 or L1 L2 junction is the site where the spinal cord ends. And after that, we had cauda, the cauda part, that are the roots are there below that. So if you have an injury at L1 level, the chances of spinal cord damage to the cord or the conus part gets involved, and that leads to complete loss of sensation with direct bowel involvement at that site. So what exactly is happening is the cord gets compressed and the circulation, which is the blood supply to the cord, and the neurons which are exiting from the cords get disturbed. So this creates a scenario of being cord in shock. So what happens if we say that the cord has gone in shock when it has got injured because of the bone fragment, because of the vertebral body which is abutting the cord, it has gone in a state of shock, and this shock creates a loss of sensation below the level of the injury. So that is what happens. So the main concept is that because of the compression, because of the burst fracture, there's a state of shock to the cord. That is what happens. Can you hear me?
Yes, sir. I'm sorry. So my next question is, sir, how do we determine whether the injury is a stable or an unstable one?
Okay, so we had various criterias for that. Basically, if we look for a physiotherapist, if we are taking this lecture, we are dealing with the physiotherapist. So what they had to see is the X-ray. First, we had to start with X-ray. We cannot say clinically whether it is unstable, stable. We can, because if we see a translation clinically, if we see the inspectory finding, there is a translation of the spinal because the columns are involved, because there's an involvement of the posterior column, there's a deformity, and that deformity suffices that it's an unstable fracture. Otherwise, in our practice, what we see the X-rays and the MRIs. X-ray, if the three columns are involved, if there's a burst fracture, what does it mean by burst fracture? The involvement of all three columns, the anterior column, the middle column, and the posterior column. Anterior column is formed by the anterior of the body, anterior of the disc, and the anterior spinous ligament. Middle part of the middle column is formed by the spinal canal, posterior half of the body, the intervertebral disc posterior part, and the posterior column is formed by the ligamentous complex, that is posterior longitudinal ligament, the interspinous ligament, and the spinous process. So if we see that all this more than two columns are disturbed, suppose anterior middle columns are disturbed, or posterior and middle columns, or all the three columns are disturbed, we see the fracture is an unstable fracture. If you see the X-ray, if we see the last slide with the way the patient's X-ray is there, so we can see that in this slide that there is a loss of continuity of the bone. There's a displacement of the vertebral piece. The vertebra is displaced. It is not aligned. So that gives the classification that all the three columns are involved. There's a retropulsion of the bone piece. And if you see in MRI, the posterior ligament complex is broken. That means posterior ligament means interspinous, the spinous process, and they are involved. So that is creating instability. So these are the main criteria for a physiotherapist, that if you look that the alignment is lost, more than two columns are involved, and if it's a burst fracture, when you see there's complete loss of alignment, there's displacement, the facets are not in line, that gives the criteria that is an unstable fracture.
Right, sir. So my next, I think you already answered what
No,
rheological
but that is
finding.
what the posterior for us. The most important thing is retropulsion of the bone piece. That if it is there in the canal, then it is the criteria that you should decompress it and you go for surgery. And one more important is posterior longitudinal ligament complex. We call it PLL complex. So that is very important, because if the vertebra is anteriorly unstabilized and if it is posteriorly stabilized, we can still go for conservative management. But if posterior ligament complex is gone, then that is the sign for fixation and surgical intervention. And we want to decompress the cord as early as possible. We want to remove that retropulse piece as early as possible. So we want to stabilize the spine so that it should not cause further damage to the vertebral, the spinal cord, the tissues around vertebra, and that gives relief of the pain also to the patient. So the main criteria, radiological finding, what is important is in MRI, loss of continuity of posterior ligament complex or edema in the posterior ligament complex, and unstable fracture with retropulse piece, and the loss of vertebrae of more than 50%. That are the criteria which fits to fix the fracture and stabilize it and decompress it.
Right, sir. So, coming to the surgical management, so what do you feel are the main goals of performing early decompression or and fixation?
Yeah, so again, that's what I'm coming to, that as early as possible, because the spinal cord is in the state of shock. That means it is recovering from the injury, what has happened. So if you say, suppose I take a scenario, a patient is in the shock, what you do? You start resuscitating the patient. What you do? Remove any airway bleeding, you remove that airway part which is choked, you maintain the circulation. So that is what is required when you do same thing for the spinal cord. The time you come to know that you are having the issue with the cord being compressed by retropulse piece, you know it's an unstable fracture, the slight movement can cause further damage to the spine, and the patient is in a spinal shock. So chances of recovery are more once you fix it. So early decompression fixation, the main goal is to relieve the patient of the pain, to prevent further injury, and to provide a decompressed cord so that no further damage can happen.
Right, sir. So then, so how is we looking for what is the important in the time of surgery in the spinal cord injuries? How important is
Definitely.
timing basically? Matlab, how early we
Yeah.
should proceed, or we should delay, or we should wait for the surgeries? How do we decide that, sir?
if a patient is stabilized, if it is hemodynamically stable, he or she is hemodynamically stable, and you feel like that patient can be taken for surgery, you should do the surgery as early as possible. Because what you want is to decompress the spine as early as possible. If you don't decompress it, that compression can cause further damage. You have seen patients of disc prolapse and all that. At the time we decompress, we get the neurological recovery. So the recovery is not the main aim. The first aim is to stabilize and damage. So damage control is important. What we do with the stabilization, we control the further damage to the cord. So once you stabilize, the cord is stabilized, the vertebral column is stabilized, it is decompressed, the piece which is retropulsed is which is compressing the cord, is the pressure on the cord is relieved. So these are the main. As early as you do, the chances of recovery increases, because that gives more chances for the cord to get survived. And right now, as you see, what is most important is this patient anal reflex is absent. So this is a very important criteria for orthopedic surgeon and spine surgeon. The absence of anal reflex. That means the cord has still chances of recovery, because there is still continuity of the cord with the local reflex arc, which is still controlling this. Once the anal reflex appears, that is the worst sign. That is a worst prognosis for the patient, because that shows that the patient is out of spinal shock. And once you do the retropulse piece, you remove, the chances of recovery are still less, very less. So the time the patient in shock, when the patient is in spinal shock, the anal reflex is absent, that is the time you should operate as early as possible. Because once he is out of shock, the chances of recovery reduces. It reduces by a marked percentage. So the timing of surgery is as early as possible. When the patient is in shock, the time you operate, you remove the compression part, you decompress it, you fix it, and that will give the good results.
Thank you, sir. And so very important key, what complications should, as physiotherapists, we should be cautious about in the early post operative phases?
Only thing what we are concerned is, when we have fixed a spine or anything, patient is already very much traumatized. So what happens is, it's a fixation which is very important. If you are done a stable fixation, I think we can mobilize the patient as early as possible. But the fixation is not stable. If you feel like the vertebrae are not holding the screws, the patient is very much osteoporotic. The patient has many like metabolic disease and all that. The mobilization, like weight bearing, like making the patient stand, patient, you can do patient bed turning and all that, but you should not put him on the position that can put load on the spine, because sometimes that causes the screw back out and all that. So in the initial phase, if the patient is recovering from shock and all that, try to do minimal mobilization of the patient. You can mobilize, if you had a good fixation, you can mobilize the patient with bed turning and all that, so that he can start his activity. But for physiotherapist, I think the best thing is that you should be in the positive room. You should not, because patient is already, what happens is, patient is already neurological compromised. He has orthostatic hypotension also, because of the disuse of the lower limb and all that. He will have blood pressure issues and all that. And if you try to mobilize them very early, they can end up with shock, cardiovascular shock and all that, because of the reduced venous return and all that. So what you have to do is, you have to stick to the basics of the rehabilitation, that you start with the process. The patient's hemodynamic stabilizes, the patient mechanical stable. If the wound is good enough, there is no bed, so they know wound around the body. So that time, if you see then everything is in good scenario, you can start mobilizing and rehabilitating the patient.
Right. So before we proceed to the rehabilitation portion, I would really like to ask, what is the prognosis for this L1 complete injury? So what level of recovery should, as a clinician, we realistically you can expect from the patient? And
Oh, that's a very difficult question to answer, because everyone is expecting this thing only from our spine surgeon. That's how it is going to recover, and what do you think is the recovery part? I think the first time you meet the patient, it is very important. If you're clinicians, you had to decide how to break the news to the patient, that what has happened to the patient. So if you explain very clearly to the patient that what is the scene, what has happened to the things, and the only thing is, you had to, because patient is in shock. So what, spinal shock. So you can tell them that we are doing all this process, we are stabilizing, recovery is guarded. If there are chances of recovery, we are going to observe it with your efforts, with the physiotherapist efforts, and with the surgeon being decompressing the cord, chances of recovery are there. Seeing this scenario, you should never give a complete assurance to the patient that you will recover completely. It is never the finding. Recovery is more on the practical part, how much you have decompressed the cord, what is the status of the cord, how long the patient is in spinal shock. If the patient is in spinal shock, recovery chances are more. But what we expect the patient, that you, it will take almost a year that you will get something in your body, you will get some recovery part. The bladder ball part will be the last to come. So be assured that you have to take care for yourself so that you can make the things good for you. But still, that's a very difficult question to answer in the present scenario, not even past, not in the future. You cannot answer that how you can explain the recovery. Some patients do recover very fast, but you have to do adequate decompression, adequate fixation, and a good rehab protocol will make them rediscover the weakness, the paraplegia what they have. So again, recovery, I'll say cord status. Right now, we had things that we go for EMG, NCV studies, and all that. Basically, the appearance of the bladder ball function, and they are very important. So if you fix it early, if you decompress it early, chances of recovery are there, but we cannot accept a full recovery. There are chances that it could recover, definitely.
Thank you, sir. So after this, I think we'll move ahead toward the acute or a very early rehabilitation phase, which we usually believe is very, very important. So Dr. Chitra Kataria ma'am, my question to you is, so once, as sir has explained us all the medical things, how we can expect, and then the surgeries has been done or the patient is now stable. So ideally, what time or when should we basically begin the physiotherapy?
Yeah, thank you for inviting me to be a part of this panel discussion. And with regard to the question on when physiotherapy should ideally begin. So physiotherapy should ideally begin as early as possible, usually within 24 to 48 hours after surgery. Once the patient is medically stable, spinal stability has been ensured and clearance has been obtained from the surgical and medical team. So in this particular case of a 28-year-old patient with traumatic spinal cord injury at T12L1 level, ACIA complete injury. So, and patient has a GCS of 15, indicating full consciousness. So this allows the patient to actively participate in early rehabilitation. And early physiotherapy is important because it helps to prevent secondary complications such as pressure sores, chest infection, and DVT. It also helps in maintaining joint mobility and muscle strength while supporting the respiratory function and circulation. So rehabilitation in spinal cord injury now begin during the acute care phase itself, and physiotherapy plays a very crucial role in preventing the complication and preparing the patient for long-term functional recovery. So, and early intervention also support the psychological adjustment to the injury and helps lay the foundation for future functional training and independence. So, physiotherapy ideally be started as early as possible in order to ensure the best result, and should be administered along with the other members of the interdisciplinary team.
Sorry, ma'am, there's a glitch.
I have seen that my next question was, what are the key goals of physiotherapy first week after spinal cord injury? So it was on the slide. So let me discuss with that. So in the first week after spinal cord injury, the main goal of physiotherapy are preventing secondary complications and maintaining the physiological stability while preparing the patient for the later rehabilitation. So the key priority is maintaining respiratory function and preventing pulmonary complications. We should also focus on preventing joint range of motion and preventing complications such as pressure ulcers, muscle shortening, and DVTs. And in patient with complete lower limb paralysis, the emphasis is placed on skin care, improving circulation, and initiating the early bad mobility as tolerated. And at the same time, the upper limb strengthening and trunk control also initiated gradually to prepare the patient for future activities like wheelchair mobility. And it is very important that patient and caregiver should be educated on the positioning, skin care, and long-term rehabilitation is also a very essential part of early phase. So overall, the first week is critical for stabilizing the patient and preventing complication and laying the foundation for successful long-term rehabilitation.
Thank you, ma'am. This was really insightful. So my next question to Dr. Jayashree ma'am is that, ma'am, how can we prevent early complications in spinal cord injuries? Like we have seen, pressure sores are very commonly there, chest complications can be there, joint contractures. So how as a physiotherapist we should look into this, that we prevent, and because these complications, they really affect the prognosis of the patient.
Thank you. Thank you very much for giving this opportunity. Uh, Early complication, these are the pressure sores and chest complication, joint contracture due to the prolonged immobility and loss of sensations. So you can prevent this complication through the proper nursing care and early rehabilitation measures. So pressure sore which occur due to the prolonged immobility and loss of sensation. So you can be prevented by regular reposition every 2 hours in bed and every 30 to 60 minutes in chair if patient is in wheelchair, using the pressure relieving devices like the foam or air mattresses, and maintaining the good skin care by keeping it clean, dry and moisturizing. These all are coming from the nursing care, and daily inspection of bony prominences like the sacrum and heel, and avoiding friction or tears are also essential for, along with the caregiver education is also important. Like the and chest complication also arise from reduced mobility, leading to weak cough and secretion retention. And these all can be prevented by encouraging deep breathing exercise, incentive spirometry, segmental expansion exercise, and assisted coughing technique and chest physiotherapy when and needed, along with the early mobilization and like the percussion and the vibration if a high level of injury. Joint contractures can be caused by the muscle imbalance and prolonged static positioning. So it can be also prevented through the daily passive range of motion exercise, regular active exercise on unaffected side also, and regular stretching of muscles such as the hamstring, hip flexors, Achilles tendons, and proper positioning, and the use of splint if necessary when the patient is in bedside. Thank you. Hello.
Thank
These
you,
all
ma'am. Yes, ma'am. I'm there.
okay.
Thank you, ma'am. It was really good to hear that, because we always feel that early complications need to be prevented at the priority level. And next question to Dr. Nalina, ma'am. Ma'am, what do you think are the positioning strategies basically which are important for a spinal cord injury patient? Because I think somewhere these strategies will really help to prevent these early complications, which madam has already addressed.
Thank you so much for your question. Rather, I really would like to emphasize here is that the positioning strategy may not begin in the early post-op phase. Many times what happens is a patient is in the ward and has not actually have undergone a surgery because of XYZ reason and because of financial constraints, and has been even referred for physiotherapy. And now the spine there is not that stable enough. So now I think our positioning strategies and positioning and the handling of the patient becomes important at that point also. And how we are handling the patient, because our handling or our positioning at that particular time should not deteriorate the condition of the patient. Rather, it has to, maintain the position of the patient. So that kind of an education also has to be provided in the pre-op phase, even to the the local staff or even to the family members, because this is something which I have noticed and I've observed also in many of the areas, that many of the times this handling and the positioning in the pre-op phase goes wrong, and that sometimes may probably lead to a deterioration of the cases. Now, coming on to the positioning strategies after post-op also, it is a very, very important, because ultimately we need to align the spine in a neutral alignment, right? So that is the basic goal, that the positioning has to be done. And if I merge it with the other complications also like pressure sores, which Jayashree ma'am has already discussed also. So we will have different positions where, with the help of pillows, with the help of sandbags, or sometimes with the help of the water which is filled in the gloves, we can use those gloves also. And so we can position the patient with the help of pillows in supine lying position, sideline position, depending upon the patient's status, and which will be, utilizing the turning also after every frequent hours, we'll be doing it. So if I go ahead with the supine lying position, so we might use a pillows, okay, and a pillows which is keeping the spine in a neutral position, two pillows which are supporting the arms, the one pillow below the head and neck. And then we have the two pillows even at the side of the leg so that the leg is not going into the external rotation position. And where we have a sandbag which is further supporting the feet also. Similarly, when we are moving the patient into a sideline position, further a one pillow below the head and neck, and then one between the legs and one between the arms, which can be utilized. Now, another very important point we should always keep in mind is that we always say that after every 2 hours on a regular intervals, we should, turn the patient. But turning the patient also depends upon many factors, like which geographical location right now we are residing, what is the temperature there, what is the humidity level there. So I may have to sometimes the turning time, I may have to increase or decrease depending upon the weather or the humidity or the temperature level wherever my patient is. Because ultimately we just want that the positioning, the neutral spine alignment has to be maintained. Okay, and we have to definitely work along with the orthopedic or the neurosurgeon, whoever has has done the surgery to the patient, right? Yeah, thank you.
Thank you, Dr. Narayan. That was really insightful. Because as you added that definitely we need to decide that, because it has been taught in the books since so long that every 2 hours you should position. But your key experience has spoken that definitely we implement things. So that is wonderful. So proceeding to the next thing, we have the next inpatient, I'm sorry, it goes, but still. My first question for inpatient rehabilitation is to Dr. Chitra ma'am. So ma'am, once the patient enters a rehab program, so what do you feel are the major functional goals which will be taken ahead?
So once a patient enters a structured rehab program, the rehabilitation team should first establish the expected functional outcomes, including short and long-term goals based on the neurological level of injury. As spinal cord injury affect all aspects of individual's life, including physical, emotional, social, and vocational aspect. So goal setting is a very critical component in spinal cord injury, as goal gives the direction, focus, and structure of the development of the therapeutic program. So we should set the practical, realistic, and a customized goal before we start the therapy program according to the level of injury and patient requirement. So, and patient and caregiver also involved in each goal planning meeting. So in patient with complete L1 injury, in this case, the preserved upper limb and partial abdominal muscle provided a good trunk stability. So at this level, the patient can become fully independent in all his activity of daily living. So the major goals include the bed mobility and sitting balance, including rolling and from moving from supine to sitting and maintaining independent sitting balance with support and then without support. And emphasis should also be placed on strengthening the upper limb and building endurance, so as the arm become the primary source of mobility and functional independence. So once the patient achieve good balance, push-ups, and good upper limb strength, the transverse training should be initiated. That should be focused on developing the safe and independent transfer, such as bed to wheelchair, the same level transfer first, the wheelchair to commode, and then high and low level transfer like wheelchair to floor, and then long-term goal is the car transfer. So another important goal is wheelchair mobility, basic and advanced wheelchair skills that include the independent wheelchair propulsion and on the level surface first, and then ramps, uneven surface, and curves and terrain. So, and for this L1 injury, a key focus is therapeutic standing and ambulation training Also, with the bilateral KFO or HKFO and assistive devices, we can achieve the limited or household ambulation mainly for therapeutic purpose or short distance movement. And other key goals include the bladder, bowel, and skin management with training in pressure relief, hygiene, and self-care to ensure the long-term health and independence. And finally, the community reintegration and vocational goal that include the psychological adjustment and patient education, independent driving in long term with hand control if required, and preparation for the return to work and social participation. For this patient, our focus should be on active physiotherapy, active rehabilitation. That means that the individual takes an active role in rehabilitation and achieve the maximum level of independence. So active rehab include like wheelchair skills, wheelchair sports, bed mobility, transfer training, and recreation therapy. So these should be our goal for this patient.
Thank you, ma'am. As you said, definitely goal planning is a very critical point, because it is not only involving the patient, but although the another team members along with the family members, because it gives ultimately the level of independence we want to achieve for them. So my next question goes to Dr. Jayashree, ma'am. So, ma'am, as ma'am already said, ki we have upper limb strength present in this, and we have few abdominal. So, how do we now train this trunk stability in L1 spinal cord injury patients?
Thank you. In L1 spinal cord injury, there is a partial control may be preserved. Suppose upper abdominal is preserved, mainly so you can focusing on the strengthening of the abdominal, back extensors and pelvic muscle. So you can improve upright sitting balance and functional independence, as Chitra madam said. Training included that is seated balance training, core stabilization, transverse abdominis contraction and resistance training. So in early stage, supported sitting using the back and arm support, and along with mirror feedback you can give, and basic weight shifting in sitting. Then progression is made to static control in unsupported sitting. Then more emphasis given on the isometric activation of the trunk muscles, and dynamic control is then progressed to introduce through the reaching activities, weight transport forward and lateral. Then balance training involves sitting on unstable surface like therapy balls and perturbation exercise you can give. Different functional tasks you can like the dressing in sitting, ADL activity you can give given, and bed mobility transport and wheelchair balance, followed by advanced activities like the Swiss ball exercise and reaching beyond the base of support and dual task training you can also given. Resistance exercise for core muscles, which strengthening the include the resisted trunk movement such as flexion, extension and rotation using manual resistance, or you can use the TheraBand. So main focus on balance, control and functional independence. So in seated balance exercise and core stability exercise, transverse abdominis contraction and resistance training, which is performed on Swiss ball or the edge of the bed to activate the core muscles, and include the reaching for the floor, reaching overhead and maintaining the balance during the arm movements. Core stabilization create a vacuum effect by pulling the belly button toward the spine while breathing, which improves the deep abdominal stability. Back extensor strength can also be performed seated trunk extension by leaning forward and returning to neutral position. Trunk rotation by lying on the back with knees bent. Gently rotate the knee from side to side and that engage the oblique muscles. Progressive resistance can be given, resistance band, lightweight, or rhythmic stabilization. So all these support consideration, use of mirror for visual feedback and ensure the therapist is present for spotting initially. But before giving all these exercise, you always consult the physiotherapist. Thank you.
Thank you, ma'am. Thank you so much for your answer. So, ma'am, my next question goes to Dr. Jayashree, ma'am. So, ma'am, as you said, we have upper limb strength present in this, and we have few abdominal. So, how do we now train this trunk stability in L1 spinal cord injury patients?
Thank you.
Thank you, ma'am. I think trunk stability is very much needed because the next question which I'm going to ask, I think Dr. Nalina will agree with me. So, I believe trunk stability is required when we move ahead for this important thing, wheelchair. So,
Yes.
Dr. Nalina, my question next to is, so what wheelchair skills should these patients learn?
Uh, yes, Dr. Jaspreet, thank you for the question. And yes, I do agree that trunk stability is required for this patient. Now, when I talk about wheelchair skills, now the skill training where I have to give. So if I have to give in a hospital, for example, a skill training, now there are two options I will have. Either I'll have a wheelchair which is available from the hospital, or secondly, I'll may have a customized wheelchair. So now if my patient is not having right now a customized wheelchair and has a wheelchair which is available in the hospital, so at least the two things should be there, that it should have a wheel rim, and secondly, it should have a removable armrest. So these two things should be there in the available wheelchair which is there in the hospital, but rather it's always preferred to have a customized wheelchair and a wheelchair which needs to be prescribed to the patient depending upon his condition. So there will be many factors which will be influencing the wheelchair prescriptions, like what is the patient's physical condition, what is his financial constraints, and what is his preferences. Now, once I have a wheelchair, now the wheelchair skills which are normally being taught is, before we go for a wheelchair skills, there are 4 wheelchair stroke patterns. Okay. One is flip, where I'm just flipping the wheel, right? Second is you have a single loop. There could be another stroke pattern, which is a double loop. And there's a fourth one, which is a normally used by the patient with paraplegia, is semicircular. Okay. Because semicircular stroke pattern is the one which actually will cause less energy expenditure in a patient with paraplegia. Now, if I talk about this L1 complete paraplegia case, the wheelchair skills definitely we need to teach them, because for the longer distances, he would require a wheelchair skills for his energy to be conserved for other activities. So the skills what has to be taught to him would be, moving forward in the wheelchair when he's sitting on the wheelchair, how to move forward, how to move backward, how to turn, how to go for wheelie, how to ascend or descend a slope, how to clear an obstacle if it is lying when he is ambulating with the help of a wheelchair. So these are the skills which has to be taught to him and to make him independent. At the same time, there also should be a environmental transference also, because all the trainings what we will be doing is, the trainings will be doing it in a very in a setup, in a clinical setup or in a hospital, we'll be doing those trainings. Patient has to be taken outside to the road or to the uneven surfaces or to the even surfaces, and patient has to be practiced in the real context he has to practice. So there should be a transference of a training also in a different environmental context when we are going for a wheelchair skill training. So there are 3 very important things which I would further summarize is that what kind of a wheelchair we have, whether available or a customized one. Secondly, what type of a stroke pattern my patient will be using. And third is what skills I'll be, teaching him. And then further, I need to transfer these skills in a different environmental context for him to be as independent as possible in his home environment, right?
Thank you, Dr. Nalina. I think that was very insightful because this is where I feel always the patients are facing a biggest challenge, because this is the biggest thing. Ambulation is required to do their ADLs, and we definitely look forward for this. So my next question is, when wheelchair skills and they need wheelchairs, so I believe is there that they need any assistive devices or orthoses also, or it's only the wheelchair we need to train into them?
L1 complete paraplegia, if there's a level between T12 to L2, they can very well walk with the help of KFOs bilaterally with the help of elbow crutches. So they can be trained for that. The only issue comes is the energy expenditure is comparatively higher. So for the shorter distances, we have to train them. For the shorter distances, they can utilize it. But yes, for the longer distances, they have to rely on the wheelchairs. But yes, they have to be trained for the with the assisted devices, the ambulation with the assisted devices.
So it's a key point to note, everyone. For longer distances, as Dr. Nalina said, wheelchair is very important. So those wheelchair skills, which she has already mentioned, they should be looked further into this. And further, it's for a very good point that assistive devices for shorter and making them feel more independent in the home itself, they can use assistive devices to move around.
Because I think standing and walking on your feet, however you are walking, maybe with the help of assistive devices, definitely is going to make a difference as compared to the one who's sitting on the wheelchair and ambulating.
Okay.
So it definitely is going to have a psychological impact also.
Thank you, ma'am. Sir, I mean, I'm coming back to you with this thing. It's the same question. So,
Yeah.
what do you feel after these inpatient and still we can give them a prognosis that they can walk or not, realistically?
I think as a surgeon, what I say is surgery is not for recovery. It is just for stabilization, decompression of the cord. So the time we meet the patient, we never tell them that this surgery is for your recovery. It is just for stabilization and decompression of the cord. Recovery will take time, and it is like we can say that it's if it recovers the condition of the cord, we can say that these are the chances. We can give them chances that these are the chances of recovery. We cannot assure them that you will recover completely, but a good that's what when we meet the patient, when we meet a patient with this sort of L1 injury with a complete paraplegia, what we say is that, and what we feel, we had operated many patients. Surgery plays only 10% part. 90% part is the rehab part, the physical rehabilitation, the mental rehabilitation, the psychological rehabilitation, and the vocational rehabilitation. So we should make this community, this people who are with paraplegia, that the recovery chances prognostically there are chances because your spinal cord is in shock. So we can give them some assurance that there are chances of recovery, but surgery is not for recovery. The main thing is how much you rehabilitate the patient, how much you make them feel that they are part of the society, how can they can be functional, how can they use their disability to a level that their disability can be an ability for the society, and they can survive and they can do something good for society. So that is more important rather than the surgical part explaining the prognosis to the patient. Prognosis, yes, we can say as patient is in shock, the condition of spinal cord, there are various MRI setups, tactography is there, various MRIs are there, which gives us idea that how much chances of recovery are there, with the how much the cord will recover. We'll see the progression, and from that we can make out. But still, it's very guarded. You should be very clear to the patient that this all things are for your future rehabilitation. It is not for the thing that how much you will recover. And never assure the patient that you will recover completely. That's a false thing. What happens? We do see patients coming to us and they are there for the purpose. Sir, we went to this doctor, he told that once we operate you will recover, but they don't recover, and then they come to us with the same thing. Sir, why we are not recovering? Do something to get us recovered. There are many things like stem cells are coming, and all. Let's see the future, how the future works, how the stem cells and the waste technology work. But what I feel is prognostically we cannot tell right now. If the patient is in shock, spinal shock, we can tell that there are chances of recovery, and what we say is you have to observe it for at least 1 year. So if you observe it for 1 year, that are the chances how much you can recover. But after 1 year, if there's no progression in the recovery phase, you can bluntly tell to the patient that now you won't be recovering. That is the end of your phase where you can think of something is going to happen to your limb.
Thank you, sir. I believe we all understand that patient has into been this rehabilitation for long, and because it's a very long phase to recover, and definitely there's a lot of frustration and there's a lot of loss of motivation, and patient is frustrated because he cannot go back to work early. He's dependent on so many people, even the family members. They become it's difficult for them to make them understand. So here again, I'm coming back, Dr. Chitra ma'am, to you. Already Nalina madam has said about, told us about wheelchair and this orthosis, but still, really, is ambulation possible in them, or we more they have to be dependent on wheelchair mobility only?
No, as Nalina already discussed, that ambulation may be possible with L1 level spinal cord injury or lower level spinal cord injury, but it usually limited to and mostly considered therapeutic rather than fully functional. And with regard to with the proper rehabilitation, so many patients with L1 injury can manage short distance or household walking using bilateral KAFO or HKFO along with walker or elbow crutches. But however, because there is no motor function in the lower limb, and walking with braces takes a lot of energy. So wheelchair mobility is generally more practical and efficient for daily and community services. So our main focus in rehab is helping the patient become independent in wheelchair use, transfers, and daily activities. Walking with orthosis can still be practiced as it can provide the additional benefit, as Nalina already discussed, that such as improving cardiovascular fitness, maintaining joint mobility, preventing secondary complications like osteoporosis, and supporting psychological well-being. And depending on the patient motivation level, physical capacity, and our rehabilitation goal.
So, ma'am, we do believe that definitely if the patient has willpower, this orthosis can really help them for shorter distances.
Yes, therapeutic walking we can encourage for the lower level spinal cord injury patient.
Right, ma'am. Ma'am, if you want to discuss something you have seen in L1 in a recent thing, please let us know if any case.
Many patients, we encourage every thoracic level to lumbar level patient to encourage therapeutic walking. We give them the orthosis KFO or HKFO as per the patient requirement, and then daily they can practice the walking, therapeutic walking. Initially, other activities like first tiltable activity, or we stand them on the O-frame, and gradually we start with the walking practices with the orthosis.
Thank you, ma'am. So my next question to Jashi ma'am is, ma'am, what do you believe? What are the newer technologies? Because we are so much hearing there is AIs in there. So there's so many ARs, VRs are coming up. So are there any new technologies in spinal cord rehabilitation also, which are playing a major role right now? Hello.
Yes. In spinal cord injury rehabilitation, there are so many newer technology, but it may be costly. And so in spinal rehabilitation center, there are so difficulty to purchase this newer technology. But its key role by enhancing the recovery and independence and task-specific engaging rehabilitation. So this new technology makes spinal rehabilitation more precise, efficient, and patient-centered, and that leading to faster and greater independence, and then improve the quality of life. But newer technology also plays transformative role in spinal rehabilitation. So shifting this focused compensatory strategy to the restorative intervention that promote neuroplasticity, enhance functional independence, and improve the quality of life. Newer technology like the robotic and exoskeletal assist walking that provide repeated movement and task-specific movement training, and which improve the walking ability and endurance. Then wearable sensor monitor movement and posture and mobility that provide feedback and progress the tracking. Virtual reality and augmented reality that patients engage in balance and coordination exercise, then improve the motivation and provide real-time feedback. AI-driven program personalized therapy that can also be newer technology. Tele-rehabilitations, which allows the ongoing monitoring the patient at home and improves the care and follow-up. Then body weight supported treadmill also use that support the partial weight bearing during walking, and that promote the early gait training and enhance the neuroplasticity. So these tools complement physiotherapy to improve the outcome and accelerate the functional recovery, which prevent the muscle atrophy, improve the circulation, and provide the psychological motivation and enhance the neuroplasticity. But it is limited in the complete spinal cord injury. These are the adjunct tool, but not replacement for functional independence. Thank you.
Thank you, ma'am. Dr. Nalina, this is something which I'm going to ask is I feel is very important. We all we are all discussing that we should train this, we should do this. I mean, we should help them learn these skills, learn these techniques. So I basically wants, does a physiotherapist is also playing a role in the psychological rehabilitation and family education? And if so, so how do you feel? How important this point is it?
Yeah. See, I think it is really a very important point, and it does not come after days or months. Rather, it comes in the beginning only when we have to plan for a patient's treatment. Why? Because we really have to, how I think Dr. Piyush sir also has mentioned that we have to break the news, right? He said in the beginning. So how empathetically and how, setting the clarity into what we are saying, we really have to, make the patient understand exactly what has happened and what exactly is expected regarding his improvement. Unless otherwise, what happens is that if you ask any of the patients that what do you want, they will say that will I be able to walk again, or when I will be able to walk again on my feet. So these are, so we will not be able to set the realistic goals unless we actually tell the patient exactly what is the problem and what is expected, and then probably we can set the realistic goals with the patient. So I think the psychological rehab becomes very, very important, and we really have to ask the patient expectations. Because for example, for me, my expectation would be just that sitting and doing some household core probably is my expectation. But in my rehab setup, they are making me do all other sort of exercises. But what I want is not being happening. So in spite of having improvement in all other domains, but the thing what I wanted has not been done, I will never be satisfied. And that is, the patient will always say that, my expectations has not been met, and I'm not satisfied with the therapy sessions and all. So we really have to sit with the patient, make the patient understand, set the realistic goals with the patient that if this is a scenario and this is what we're gonna set. And very importantly, we never tell the patient that, you will not be able to do this. Rather, we always give him options that, there are many ways that we can work on a wheelchair. There are many ways we can work with the orthosis. And if possible, we also make the patient sometimes meet the peer who has actually undergone the same problem. So he probably can meet a already rehabilitated a person with a paraplegia. So he can actually understand that, yes, if this person has done so much after the injury, so probably even I will be able to do it. So psychological boost up is very, very important, and patient expectations should be asked. Patient needs, patient's preferences should be asked when we are actually setting our goals.
Okay.
Because unless my patient is satisfied, then rehabilitation will be zero if we are not satisfying what he exactly wants.
I personally believe and really think that definitely the goals have to be, as already Chitra ma'am said, that setting goals are very critical point and we have to involve all. And I think the patient is the foremost, which who should be involved into this, that what he wants actually from the rehab, from our ones. Chitra ma'am, before proceeding forward, I'll just ask you to share your experience about the community reintegration. That is very important. So we've done everything. We've given them an advance. We've sent them home. We've done all the trainings. So this is a question it came to my mind that how have you, because you have vast experience. So how do you feel this community reintegration happens, and what is basically the role of a physiotherapist into this?
Community reintegration, very, very important aspect of rehabilitation of spinal cord injury. So for community reintegration, before the discharge, we take the patient for outing, for accessible mall, accessible places, for shopping. So these kind of activity we organize. And also every day we organize the sports therapy program. So in the evening, all our patients play sports outside the hospital only in the campus. And again, important aspect, once in a week, we also organize the dance therapy program. So it is rightly said that if you want to heal the body, you should heal the mind first. So, and many other community activities, like we have a small vocational unit So like computer teaching and diya making, candle making, these kind of vocational teaching, vocational training also, and counseling also. So these kind of activities we organize for the community reintegration for the patient on regular basis. We have social worker, so she takes care of all these things.
Thank you, ma'am. I believe definitely after all the things we need to give them back to the community. They have to be a part of the community and the society where they can again work accordingly to their demands and needs. So proceeding further, this is just simply, very important, ma'am. We already spoke that early rehabilitation is important in this, but from your perspective, how do you feel that how much early the rehab starts, so it will help in the how will it influence the recovery of the patient?
Early rehab is very, very important after a spinal cord injury in overall recovery. So even though its direct effect on neurological regeneration is limited, especially in complete injuries like ACI, where recovery mainly depends on the level and severity of the injury. So starting rehab early helps in optimizing the biological and functional environment for recovery by improving the circulation, maintaining musculoskeletal and cardiopulmonary function, and reducing secondary damage that we have already discussed. And research shows that early therapeutic intervention may also stimulate the neuroplasticity. And so in addition, the early rehab helps in preventing the secondary complication we have already discussed, such as pressure ulcers, joint contractures, atrophy, and respiratory complications. So even if neurological recovery is limited, starting rehabilitation early makes a real difference in functional outcome. So it promotes independence, support psychological adjustment, and improve long-term quality of life, which is why it's such an essential part of post-surgical management of spinal cord injury. So early rehab is very, very important aspect.
Thank you, ma'am. So I think this is the big key message to the fraternity that definitely we should look forward in consultation, that how early we can begin and we can benefit the patient into this. So my next question to Piyush sir, from your perspective, what communication is essential between the physiotherapist and the doctors for the optimal patient outcomes?
I think the best part is never consider that you are the best, either the physiotherapist or the orthopedic surgeon or the spine surgeon, that it's a team work which is important. So being in communication with the physiotherapist is very important, because a physiotherapist is a person who is dealing with, once the surgery is done, once the patient is out of our ward and he's in rehab, the physiotherapists are the people who are dealing with him more than what we are dealing with. So, what are the changes which are happening to the patient once they're going for physiotherapy? If they're developing some contractures or something, if they're developing some new, if they gain some sensation, if they gain some power, it should be communicated properly to the orthopedic surgeon or the spine surgeon who's operated. Because development of contracture, you need further release of the contracture to rehab the patient. What happens is, if we send a patient for a rehab to a physiotherapist, they don't come even after months or years. They come back with contracture, bed sores, and everything. And I think physiotherapists are the people who deal with them daily. They give physiotherapy, they make them rehabilitate. So a proper communication is very importantly required for the patient to recover fast, for the patient to gain his access to the various system. So a surgeon, if it is in communication with a physiotherapist, a patient do much better than without the communication, because there are many changes which happen. Suppose there is worsening of the neurology, something has happened above the level. So if it is not communicated to the surgeon, then it will be blamed on physiotherapist that they had done something wrong. That's why it has happened. So there's a blame game which happens between surgeon and the physiotherapist. So to avoid that thing, you should address what is happening to the patient. If there is some recovery, you should address it to the surgeon. If there is loss of something, loss of neurological deficit, you should address. Prevention of bed sores, what are the modalities, what are the surgical intervention can we do to rehabilitate the patient. So that communication is very important. So once you are dealing with patient, a constant communication, regular follow-up to the patient with the physiotherapist, and no doubt, ego is the issue which has to be kept down. You should not be there with the ego that I am the surgeon. Why should I talk to a physiotherapist? Why a physiotherapist should not talk to a surgeon? There should be a common talk, common platform on which both has to stand and decide and do the best for the patient. That is what the most important thing is.
Thank you, sir. That's very great that we need to maintain that communication. So similarly, Jayashree ma'am, what is, as a physiotherapist we need to have? What do you feel we need to communicate or we need to address with the surgeon? Hello, ma'am. Hello.
Hello.
Yes, ma'am.
As a physiotherapist, the communication between physiotherapist and surgeon is very useful because the physiotherapist must communicate the patient's functional status or progress, and surgeon also communicate stability of the spine, whether stable or unstable surgery, type of fixations performed, which is important, movement restriction, if any weight bearing status that communicate by the surgeons also, and if there is any difficulty in mobilization, then physiotherapist must communicate any complication, as user says that sign of complication, you can also communicate with the surgeons. Any pressure source, then any complication like the autonomic dysreflexia, orthostatic hypotension, these all are communicate with the surgeon and physiotherapist. Thank you.
Thank you, ma'am. So, Dr. Nalina, now this is a big question. We've seen Western countries, whatever we read, I think more of literature and researches is from them. So, but I think it's difficult to implement here. So, what do you feel are the biggest challenges in spinal cord rehab in India, considering our own place where we are working?
See, I think that our challenge first start at the site of accident itself. So while I was, in one of my studies, while I was interviewing many of the patients with paraplegia, so they always had this thing that, when we got hurt and we were not feeling that we had any sensation below the, elbow, the legs. So the nearby people were making us stand or making us sit or making us do any sort of, positioning at that particular time. So I think our handling, shifting and transferring of the patient from the site of accident is still a big challenge in India. So many a times I feel that that could be again one of the reasons that are many of the times maybe the patient may not have that bigger a problem is, and which has actually got deteriorated when he was being handled at the site of accident or being transferred from the site of accident to the hospital. That is the one of the challenges. Second challenge I think I feel is that I think everyone else will also agree with me that we have very less specialized spinal cord injury centers in India, where a comprehensive rehabilitation is going on. So a rehab actually would require a doctor, nurse, physiotherapist, occupational therapist, social worker, prosthetist, orthotist, our peer counselor, social worker, as ma'am also said. So we need to have a whole comprehensive, a team which is providing a comprehensive rehabilitation. So I think we are lacking those specialized centers in India. So a comprehensive rehab is not going on. And at the same time, we do not have a standardized protocols which are being available. So everywhere, wherever the spinal cord injury rehab is going on, so I think in the specialized centers, definitely there might be some protocols which are being available. But other areas, other centers which are not being specialized, so what protocols are being followed in the acute, subacute, or the chronic phase, or the community reintegration phase of the rehabilitation is actually not known. So a standardization of the protocols, some practical guidelines have to be there, how we have those guidelines. So see, more or less the guidelines are going to be the same which are being there in Australian guidelines, or we have guidelines in the APTA, or we have guidelines in the Canadian guidelines. But still, we also need to sit because our cultural, our other contexts are comparatively different. So we need to have some standardized protocol which is being uniformly followed all over India in all the setups. So I think these are the challenges probably which we need to work upon.
Thank you, Dr. Nalina. Before I summarize, if this panel is now open to questions, so Anybody who wants can write in the chat box, and I can ask the panelists for this. So if any questions, you can write in the chat box, and we can go ahead with the things then.
Jasprit, I think if we go for a community education program, that what happens in this situation is the community should be aware of that this could happen to anyone in the society.
Yes,
So
sir.
what happens is the education level, if we can put all this in the primary education system of our country, that there are things that if a patient has this sort of injury, you can how to manage, like Mrs. Nalina told that how we manage the things, what are the basic requirements has to be done, and what are the myths associated with paraplegics and all that. That how disability is like it's a burden to the society. So if we want to avoid those myths which are associated with that. So once we do that by education, by educating people that they are not the burden, it can happen to you also. It can happen to any person. We are talking about paraplegics, but what about stroke patients and everything? So we can tell them that it is not, it is part of that, it can happen to anyone, but how to come out of this thing, we should definitely create, as ma'am told, Chitra ma'am told, that role models should be there, who should be like, they had faced paraplegia and now they are doing something so great that people are aware of that thing. In spite of their disability, they are doing something great. So these role models are very important to keep them in our place, in our institution. We do keep seminars of the role models. We have paraplegics who are TT player, national TT player, international table tennis player. They come and give lectures. Okay, so that creates a good face in the environment of the patients and their relatives. That if they can do, why not my son can do? Why not my daughter can do? And then they pursue the things. So this education is very important. In Indian scenario, I think if you educate the people, they will come with the wonders. And community support, apart from centers, our family, the family system is so great that if a disabled is, we have seen mothers and grandmothers and grandfathers taking their kids with paraplegia. They take care like anything. They don't even need a rehabilitation center for that. They need technical support, but they can do much more rehabilitation. So the care that these people are not a burden. You can take care of them. You can make them walk with the help of physiotherapists, occupational therapists, surgeons. Then they are definitely going to be there. So education is very important.
Thank you, sir. So there's a question, I think Nalina, Chitra ma'am or Jeshri ma'am, anyone can answer. Somebody's asked any viewpoint on bladder dysfunctions and especially the rehabilitation part. So they just want to understand, is there any bladder dysfunction in L1 injury? I think this is the question they want to ask. So Dr. Nalina, if you want to answer, you can please. Hello?
I think I heard your question. You are asking about bladder dysfunction and all that.
Yes, they're actually asking about bladder dysfunction.
Yeah, so you can, yes, bladder dysfunction do play a very important role in a patient for rehabilitation of paraplegia. It's not what physiotherapists do. They can tell about the exercises, what the like pelvic muscle strengthening exercise, various exercises regarding pelvic muscles to control their bladder activity. But what I say is, in various rehab center, you do urodynamic study. The time the patient comes with injury, a day or after they go for urodynamic study, accordingly they see what type of bladder it is. If it's an autonomic bladder, it is a different set of bladder. What are the drugs needed to control those bladder activity, and how they can proceed for self-catheterization, all that. So they train people. They do for look for the bladder functions, and once they come with the urodynamic study that this type of bladder it is, then accordingly the physician, the surgeon prescribe the drugs that control bladder activity, that reduces the incontinence, and apart from them, how to maintain the hygiene of the activity, and the use of self-catheterization. That is so important. In our institution, we teach patients how to do self-catheterization. So that is important part of bladder therapy, what is required. So ultimately, initially, patient, when you come encounter a patient with paraplegia and all that, definitely do a urodynamic study. That is very important. And I think Chitra ma'am knows she is a part of rehab team, so she knows that how important bladder urodynamic study is for the patients with the paraplegia.
Yes, Dr. Piyush, and From the rehabilitation point of view, as a physiotherapist, so we teach the exercises like Kegel exercises, IFT also, pelvic floor IFT we can apply, but we should check the sensation. We have posterior tibial nerve stimulation that also have the good result, and on the other side, the sacral nerve stimulation also, the urologists, they use for the bladder dysfunction. But with careful assessment, after the careful assessment of the bladder dysfunction, which patient is eligible or which patient is not. So it depends on that.
Thank you, ma'am. Thank you, sir. Dr. Nalina, there's a question for you actually.
Sorry, I think there was some issue. Probably you were asking me something and I just probably got
Okay,
blank.
it's okay. It's okay. There's one
But
question for you. You've mentioned in the positioning that weather and all those effects. So somebody's asked how that affects basically.
like the humidity and other parts.
Yeah, that is what they've asked.
Maybe the area is too humid, right? So I might not. So if it is too humid, so the bed sheets may get wet even after 45 minutes or 60 minutes if I'm lying on that if I'm lying in that one position for even for 1 hour. So maybe I may have to reschedule my shifting not after every 2 hours, but maybe after every 1 hour or after every 1.5 hours. So depending upon how the weather is of that area, so humidity or temperature. So ultimately, because the area should not be damp, if there should be a dryness, the area should not be wet also in that area. Otherwise, if it is a wetty bed sheet, it's definitely is gonna lead to a pressure sore development, or it's definitely cause a sore. Right.
Thank you so much. There's a question. What are the red, yellow flags we should observe for during the initial year of rehabilitation? Chitra ma'am, if you can answer this.
Initially, the patient, whenever we mobilize the patient, in most of the patient, we see the partial hypotension. So this is the red flag. And whenever we mobilize the patient, we should gradually take them first on a tiltable activity and then O-frame, and then gradually we mobilize the patient. And this is the actually very red flags. And when we teach them the balance activities like supported sitting balance or unsupported sitting balance, so there is a chances of fall because balance is very, very poor in these type of spinal cord injury patients. So this should also be taken care of. Many patient comes to us at the very late stage for the rehabilitation. So when we do the mobilization like active or passive mobilization, so sometimes there is the chances of fracture also because they are very, very osteoporotic. So this also should be taken care of during the rehabilitation. And any deep vein thrombosis, any swelling, these complications also we should be taken care of.
Thank you, ma'am. Thank you, sir. I think we've already exceeded the time. I'll just wind up with the things now.
Dyslexia also could be one of the things which probably we can look for.
Yeah, I'll just wind up. I think we're taking. First of all, I'd like to really thank you all for being a part of this and sharing such a wonderful experience you with from clinically sir's perspective, how ortho surgeon has to work and how we have to identify the stable and unstable things, how surgeries, early surgeries are effective and how they are important. Then coming into the acute, inpatient, and the community, moving towards the community integration, discussing about setting up the goals, then taking the family along with the team. It's a teamwork which we all have come up to a conclusion that the team needs to be set up, and then only we can progress for the rehabilitation phase. Thank you so much for addressing all the challenges, and I really appreciate, sir, Dr. Nalina, when you have told that we really need to build up the awareness among the community and society, because this rehab, we are actually not able to proceed ahead or do till the end if we are not being supported by our community members. So definitely teaching them, making them aware, and maybe in future we can have such drives under the banner of IAP, who's already helping us a lot. to create awareness among the fraternity and the community. So we look forward for that. And Chitra ma'am, it was really wonderful. Jayashree ma'am, it was really great to have you both also along with this, sharing your experience and knowledge with us. And I'm really thankful for Shraddha ma'am, my co-host. She has been there along with me in organizing this webinar. And we are thankful to the attendees who have been there. Thank you so much. This was a small initiative under the banner of IAP Neuro Subgroup, so that we can bring awareness about spinal cord, which is always an untouched subject, basically, because people, as Nalina said, that we don't have very specialized centers, so bringing you all under one banner and panel was a great experience, so that people can become aware how spinal cord injuries needs to be worked on. So we're really thankful for this. And once again, I'm very thankful to Dr. Jha sir and Ruchi ma'am for providing this platform. I'm thankful for my IAP Neuro subgroup people who have been always supportive into this. So today we end this seminar, and thank you, Dr. Uttara, for all the support. Thank you so much.
Thank you. Thanks a lot for
Thank you.
Thanks a lot, everyone. Thank you.
Okay.
Thank you.
Right.
Thank you, Jaspreet.
Thank you, ma'am.
Thank you, ma'am.